So let's talk about the chronic disease temperature biomarkers. So that's our 55 biomarker panel. We take 55 biomarkers because LabCorp sets things up in panels. So when we do chemistry, we get a whole bunch of acute phase things like sodium, potassium that are important, things like that. But in terms of looking at your chronic risk, we look at really 21 of those markers on the 55 panel to really generate what we call where you are on the health disease continuum for chronic disease, and that number is your chronic disease temperature. So that's for anybody working with us, we want to lower the chronic disease temperature. That's the main thing we're looking to do. But the individual markers are important too, not just the chronic disease temperature, but what the individual markers are. So I'm just going to go through a couple or a few slides here talking about why we have to look at these, and then an explanation of how we look at them, and we generate a story of your health. And like I said, 26 now out of 26 people have come to me with some sort of health complaint. And the number one marker I'm seeing that's severely elevated is what's called their erythrocyte sedimentation rate, ESR. And I'll talk about that. I know we probably already have for a lot of folks. So let's get on with it. And, introduction and needs rationale. And really, I went to the Harvard School of Public Health, but that was just a short course in toxicology. Really, when I say this is developed by Harvard, it's developed by two renegade Harvard clinicians, Dr. Tremp, my mentor, the ophthalmologist who did labs and lifestyle factors for 40 years, looking at people that present with eye pathologies, and then Dr. Kilman McCulley, who's the pioneer of the homocysteine theory for cardiovascular disease. So chronic disease temperature, the rationale, my mentors at Harvard. From McCulley's 85, he still goes to the office every day. His world is publishing evidence-based papers on mechanisms of disease. I learned so much from him, but I learned a lot more from Dr. Tremp, because McCulley is a pathologist studying tissue. Dr. Tremp was a dang good doctor who studied people and made them better. So really what we're talking about is, I don't know why it says periodontal. We need to change that to chronic disease. We'll do that right now. What is your chronic disease status? And I have another slide where I show a line right here. And to the right of that line is disease. To the left of that line, you're healthy. But really, you're on a continuum. And the farther up the continuum you are, the higher risk you have of some kind of adverse chronic outcome. And COVID is no different whatsoever. Dr. Carter and I published a paper called Cytokine Storm, which is what kills you, and pre-cytokine storm status, and how it relates to COVID risks, but all chronic diseases. Because at the end of the day, these cytokines are elevated in cancer, heart disease, diabetes, Alzheimer's, RA, COVID. So this is what we want to do. We want to slide you down. We want to slide you down that continuum. And so here's a little thing from the Washington Post, that rag paper that Dr. Loudon sends me so many articles from. But this is, they have a pretty good headline here. Chronic inflammation is long-lasting, insidious, dangerous, and you may not even know you have it. And the only problem with that statement, it's a naive statement that inflammation is the problem. Now, inflammation is a piece of the problem, but it's the antecedents, what causes the inflammation, that we need to be focused on. And we need to focus on runaway, renegade inflammation as well. But really, inflammation is your immune system responding. And COVID has taught us an awful lot. You die from the cytokine storm, like in sepsis. You die from this rampant inflammatory process from some sort of bacterial infectious process. So this is really important. And when your body's immune system is tied up fighting something, you have that much less ability to heal from day-to-day wear and tear. So it creates this insidious process. Okay, so let's go on with some factoids. So we have a healthcare system that's acute health focused. It's only 10% of health. according to the CDC, 90% of the nation's, it's a little bit old, it's now like 4 trillion, annual healthcare expenditures are people with chronic and mental health conditions. I don't know why they have to segregate mental into a separate category. It's a chronic health issue. They all overlap. They all overlap. If your gut's a mess, your brain's a mess. If your gut's a mess, you're in a poor healing, repair and recovery status. So you're going to see elevated inflammation because your immune system is weak too if you don't have good nutrients, things of that nature. That's what's important. Since we're going to talk about heart disease a bit today, this is a really interesting article that some crazy guy sent me by the name of Richard Loudon, my Uber optometrist friend, that from 2011 to 2016, heart disease mortality has increased dramatically in the United States, overall by 4.3%. But hey, I thought we were on all kinds of blood pressure medications and statin meds, cholesterol lowering to save us and things like that. So what the heck's going on? And what they show in key cities around the country, and they pick on Colorado, Fort Collins, Greeley, Colorado Springs, presumably very healthy locations, people with good lifestyles, a lot of outdoor activity, that we see reasonably high double-digit increases in cardiovascular mortality. So obviously the system from an acute perspective is failing at managing cardiovascular. And 40, I don't like that number of significant figures. As a scientist, I call it 50%. 50% of the people are on primary or secondary prevention of heart disease using statin drugs. So if we have 50% of the population protected, how come we're not protected? Very interesting question. And then I shamelessly pick on some of the top health professionals. So we had a long conversation this weekend, Michael, with some of the top medical doctors and thought leaders in healthcare insurance, talking about Kaiser Permanente as being one of the top healthcare systems. But they're still not really motivated to make you completely healthy. You know, they're both the payer and the deliverer. So you think there would be some sort of a quid pro quo to really improve the health of the population, and they're pretty good. Yet here we have the chairman and CEO 18 months ago dying in his sleep from a massive heart attack at the age of 60. So even a system as well respected as Kaiser doesn't understand health from a chronic perspective. If he didn't die from a heart attack and had angina or, wound up in an ICU, then, he'd probably be still alive today, but I can guarantee he wouldn't be healthy. They wouldn't solve the underlying problem. He'd be on more medications. That's it. So our conundrum is the pill doesn't work, and we've all probably seen this slide. On the bottom line is spending per person. In America, 11,000, and the average of many of the other developed nations in the world is around 3,700. So we're spending 2.5 times more. Yet our life expectancy is 3 or 4 years less when you look at these nations. So why I have this arrow here, it's a very clear curve. The more we spend on healthcare doing expensive drugs and procedures, the shorter we live. So we need to avoid that. Here's some other prominent individuals that 60s, 40s, 50s, 60s, 50s, 30s, either died suddenly or had a massive sudden event in their health. And this guy here, John Warner, I use him shamelessly because on my birthday 4 years ago, he and his society, the American Heart Association, demonized coconut oil and saturated fats. So here's John Warner. He's alive today. But about 2 years ago, and you can look at it, Google it, at an American Heart Association meeting, had a massive heart attack and almost died. Now, of course, the headlines were, Dr. Warner resting comfortably after a mild heart attack. Then they interviewed the EMT that spent 7 minutes trying to get his heart running again. So he was literally a whisker from dying from a heart attack. So, and then this is an interesting slide. It comes from National Geographic.
Hey, Tom?
Yes,
Tom,
sir.
You want to go back to just the fact that when you have conferences related to heart disease, that there are less deaths for heart disease in the country during those periods of time?
This is another thing that Dr. Loudon sent me, and it wasn't published in some fringe journal. It was in a New York Times well blog, and the title went something like this. And I'll put a little sarcasm in it, but when the fancy professors from all the teaching hospitals go to the heart conference, heart mortality in those hospitals goes down. And it's completely consistent with this. The fancy doctors are doing the fancy expensive procedures, which are not saving lives. So what this study shows, this is National Geographic looking in centenarians, blue zones, trying to find out that magic gene that's holding someone to live to 100. But I can guarantee you my genes, Richard's genes, Dr. Carter's genes, and the centenarian genes are within 0.1% the same, that it's something different. And the important take-home lesson from this chart here is that if you live to 100, you have 9 years of declining health. If you live to 80, you have 19 years of declining health. So the object is to lower your mortality risk, which is what we measure in the chronic disease temperature very accurately. And the better that is, the longer you live. So if you live to 100, you gain 20 years of life. But most importantly, you've gained 30 years of good life. So that's what everybody's goal should be. So, many of you have seen our report. You get your chronic disease temperature on a scale of 98.6 to 105.6. It's a 7-point scale. And then we show you where you are and your risk for various disease states. We pick the top 5 that are most titrated to, say, diabetes, heart disease, stroke, cancer, whatever. And yes, we can measure cancer risk, and we're rolling out an algorithm, which I'll probably present next month or the month after, that completely redefines how you should be considering risk factors for cancer. And more importantly, if you've been diagnosed, what your risk of dying from cancer is. And Harvard studies, Dana-Farber, show very clear markers that will predict the severity of an outcome if you're being treated by radiation, chemo, the new biologic drugs. Very clear cause and effect relationship. And every marker we do, and we're going to present on our new cancer algorithm, are modifiable. So if you have a marker that's up, there are things you can do to bring that marker down. Therefore, to improve your prognosis of either getting cancer or dying from it. So I think these are important things. So just a quick explanation, understanding your labs. Individual lab values are important. More important is the story your labs tell about your future health when taken together. Optimal values. We've established a science-based optimal biomarker ranges through an exhaustive search of worldwide medical literature. Our normal or optimal values are those that show no increase in excess mortality based on sound statistical analysis. Your chronic disease temperature, this single value displayed at the top of your report, is the combination of excess mortality risk from many important physiological biomarkers. And I'm not going to go into any detail today, but I'll just tell you that good medical studies show what are either called risk or hazard ratios for mortality. And different markers have different risk or hazard ratios for mortality. And we use these values to create a weighted scale. So in other words, not every biomarker is weighted the same. It's based on, look, this one goes up by 10% and your mortality goes up by 20%. This one goes up by 10% and your mortality risk goes up by 10%. Those are weighted differently. But like I said, I'm not going to go into a deep dive on that. Let's see. So here's some other things we use to create science, to understand your labs. Every marker we use is called an acute phase reactant. That means something that makes you instantaneously sick will cause these labs to go up. How do we differentiate between that and a process of chronic slow perturbation in your body that also causes it to go up? So something really important is called half-life. You don't have to know this, but a half-life is if a marker goes up and the process causing that marker to go up is taken away, how long does it take for that marker to go back down? So the half-life is the amount of time it takes for it to go half, 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 half. So different markers have different half-lives. So we can use this information because we're testing some of these markers on the chronic disease temperature panel and look at the extent to which each one is up and understand the half-lives and draw conclusions about whether this was an acute event that just was leading to the relaxed and they were just like up a little bit when we took the labs, but they're on the way down, or if they're chronically up. So, and this is in my book, Quarterback Your Own Health, How to Take and Lower Your Chronic Disease Temperature, where I explain some of the labs, not all of them, in, like I said before, nauseating detail. And the one I spend the most time on is the red blood cell distribution width, a very important marker to tell what's going on directly inside the capillaries, the little teeny vessels. And at least 90% of the mileage of vessels in your body are capillaries, where red blood cells are literally going through the body, the vessel, single file. So what's going on inside that capillary expresses itself on your red blood cells. And then this is where I threw into the blog notification, understanding your labs. We look at your lab through a very different lens. Where does a biomarker show the first signs of an increase in early mortality? What story does your lab tell? And how can we tell if the biomarker is elevated chronically or just from something acute like a cold or flu, for example? So that's really what we do in terms of piecing this together. And in your consults, explaining things in that context. And, normally we'd like to have 2 sets of labs because let's just pick C-reactive protein, inflammation in your vessels. If it's up today and then fibrinogen is up too, then I can make some conclusion that it's probably been up a while. But if we have a lab today and a lab in 3 months and it's still up just slightly, now we know it's chronic. It's not an acute, not an acute event where it was settling down back to baseline. So I do not have these in a specific order. So pardon me as I run down and find white blood cells. But I think this is of all the markers, white blood cells, inexpensive test, very important and very misinterpreted. But when we do a complete blood count with differential, we get 6 markers, the constellation of which, the story of which all tell a piece of the story. Your white blood cells can be completely normal in my mortality protocol from normal, but some other ones might be a little bit out of whack, which are supporting that maybe there is still something going on even though your white blood cells are normal. So what is a white blood cell? These are the immune system, the innate response cells. Okay, so you have monocytes, eosinophils, basophils, lymphocytes, T cells, if you will, neutrophils, T and B cells, neutrophils. Each one has somewhat of a different role. Some of them overlap a little bit. And the main thing they're doing is fighting infection. So the reason why your white blood cells are non-zero is you're always fighting infection. There's always something. But at a value, which I'll show you in a moment, that's optimal, you have things under complete control. It's not an issue. When you die, you start decomposing from within. You're not interacting with the environment. So they're there all the time. That's why your white blood cells are non-zero. They're always working for you. And that's why having white blood cells that are too low is actually really bad for you. Higher, bad for you as well. But if you start losing white blood cells, like in chemotherapy, you're extraordinarily vulnerable to disease because you have inadequate white blood cells to fight the next thing that comes along, a pandemic, for example. So here's a little picture showing a little white blood cell enveloping a bacteria. I'm not going to show that today, but I'll put that link out there. But really, they're attaching themselves to a variety of different insults, from cancer to pathogens to parasites, particularly the microscopic parasites. So there's a strong link between inflammation, development, and progression of cancer. White blood cells are found in large numbers in tumors. I almost said tuna. I must be hungry. But, inflammation is what happens when you have elevated white blood cells. It's destroying something and causing a cytokine increase, inflammation. The quantity of white blood cells correlates with tumor stage and prognosis. Is anybody telling you that? So in our cancer algorithm, we titrate back to cancer mortality very accurately. So the cancer algorithm we'll be talking about titrates back to cancer mortality of all causes, all types of cancer. Whereas the CDT, chronic disease temperature, titrates back to mortality of any cause, including all-cause cancer. So just to give you an appreciation. So let's start off with a bang. Let's start off with Harvard. Look, there was a report in World News and what is it? What is it, Richard? U.S. News and World Reports 10 years ago. And at the time, I had a good friend who made David Torchiani a very wealthy healthcare provider, and he was a head of the PPO at Harvard. And I had long conversation with David Torchiani about this. So head of all the docs and healthcare providers at Harvard. But the bottom line is Harvard is number one in medical research, but at the time, Mass General was like 57th in clinical delivery. How is that possible? They're two separate industries. The researchers at Harvard, who are superior, are not able to translate their work to the clinical practitioners, even at the Harvard teaching hospitals. So, if it can't happen within their own system, how's it going to happen with your local doctor? But this is from March 2005, Harvard University. Simple test predicts heart attack risk. White blood cells sound a new alarm. This study, directed by Harvard Medical School, worldwide, looked at women prospectively. In other words, we had women, we measured them, we worked them up very thoroughly and got all kinds of markers in their health and all that stuff, and then followed and what happened to them later on and retested the labs. And it showed, and this study involved 138,000 women. A drug trial might have 1,000 people. This is 138,000 women. Women's Health Initiative and the Nurses' Health Study. Women with more than 6.7 billion white cells per liter of blood. So all you need to know is 6.7, and your lab might say 6,700. It's just the unit of measure. So 6.7 and 6,700 are the same number. It's just how the units are expressed, but in the blood, it's the same. So they had double the risk of fatal heart disease, and it was over a 6-year period, than women with 4,700 or 4.7. So Harvard says, so a count of 6.7, which is considered to be completely normal. So what is normal should be redefined. But here we are 16 years later, and if anything, white blood cell normal values, and not if anything, I can guarantee you, they've become wider. 6.7 is now considered even more normal than it was in 2005. Okay? So the standard of care today is 3.4 to 10.8, and that varies from lab to lab, but it's roughly that. So you can see 6.7 is well in it. What do I want you to be? My last consult was a gentleman, really healthy, and his number was exactly what I wanted. I looked at it, it was perfect. 4.4 or 4,400. That's my goal for everybody, plus or minus a few. And I'll show you why. But I don't want anybody with a white blood cell count of 7,200, going into some kind of panic, because in statistics there's an old expression from Samuel Clemens: there are lies, damn lies, and then there are statistics. And how statistics are a lie is they use relative statistics to tell you what your risk is. Then they use absolute statistics to tell you how harmful the drug is. Absolute statistics are the only thing meaningful. So in this study, if we looked at really healthy women at 4,700 and we looked at the 6,700 group and we go 6 years, 50% more of these have died, but very, very few of these have died because they're healthy. So on an absolute scale, it might only be like 0.1% or even less. But from a relative perspective, it's 50%. And, but the point is, for you and me, it's an increase in mortality that you don't need to have. You don't need to be walking around with. That's what it's all about. So let's look at some other things. So here's a white blood cell count, and this is the basis of my scale. And we're always altering our scale based on new data. So white blood cell count and the risk of cancer mortality in the national sample of US adults resulting from the second National Health and Nutrition Examination Survey mortality study. Very big, very popular, very well done study. So if you look here, mortality rate per 100,000 from any type of cancer, from leukemia to breast cancer, if you're at less than 5.7, and what they really mean is, they mean 4,000 or 4 to 5.7, not 2. They're not looking at that risk. Your mortality rate is 23. If you go just to 5.8 to 6.8, very normal. 6.9 to 8.2, very normal. Greater than 8.3, we don't know what the distribution is, but some of them might be abnormal, but some of them might be normal. Just by going from 5.7 to, let's say, the average, 6.3, 32% increase in cancer mortality. Nobody wants that. Yet, on your labs today, 5.8 is normal. Very normal. Very proud of you. 6.8, really quite good. So these things aren't good. And we have this duplicate slide because I was trying to make something else. But there's the curve. It's a pretty steep incline in cancer mortality as the white blood cells go up. Here. Let's see what else I have. So here's a titration looking on the other end. Low white blood cells, this is called a U or J curve. In this case, it's really a J curve. And this is true of your total cholesterol, blood pressure. So many markers follow this J curve. The low weight, if you're underweight, you have much higher risk of dying young than someone overweight. Morbidly obese and underweight have kind of the same risk factor for overall mortality and longevity. So a J curve is very prominent, and this is where we want you to be in our green, and the red is kind of where the standard of care is. So you don't, in this curve context, you don't see a huge increase, but this is the 23, 35, whatever % increase, and you can see we don't want anybody to have a white blood cell count of 2.5 or 2,500. I had a couple people in the last week with that level. They probably have something viral going on, something that's suppressing white blood cell production. Viruses will bring that down. So, a lot of people are walking around with viral burdens, they don't know it. They may feel fatigued or whatever, or some other obtuse condition, but we need to fix that 2,500 white blood cell count more than we need to fix a 10,000. That's what the J curve is all about.
Yeah, but that was too much before that.
So now we're going to run to, just for the sake of time, I'm not even going to go to neutrophils, but I'm going to go to sed rate, because so many people have an elevated sed rate. What do we call it? ESR maybe? Come to Papa. Thank you. Where is it? So sedimentation rate, it's hard to be an easier test than this. And for all of you that don't like to hear the sarcasm or pessimism towards our current system, close your ears for a second. But what I'll tell you is that old-fashioned doctors could do a sed rate in their office. Why? Because it takes 1 hour. And a good doctor visit should take that amount of time to really understand what's going on with your health, at a minimum. Okay? So what is a sed rate? I take a tube of blood. And I've lost my participant, so I can't figure out how to mute anybody. So please, if you're, oh, that's why. But if you're not muted, please mute. But so we take the tube of blood, and it's all homogenized, and we just wait 1 hour to see how much the red blood cells settle. And we can measure that very simply in millimeters per hour, so that your sed rate number is a numeric per hour, how much your red blood cells settle in 1 hour. And so we see the clear plasma, and it's, you know, you can do it with a test tube and a ruler. That's how easy it is. Okay? And this is rhetorical, but guess how much your red blood cells should settle? And the answer is they shouldn't. Yet, if you look at this diagram, they are physical structures subject to the pull of gravity, just like you and me. We're not floating in the air, we're being pulled down. So why don't they settle? By design. Because we don't want your red blood cells sticking together. Once again, 90+% of your blood vessels are capillaries where they're flowing single file through it. But they're going to be junctures where there's a whole bunch of them backed up, and we don't want them sticking together and clogging up that relief valve, if you will. So they should not settle. Why do they not settle? Well, there's some force on them that's stronger than gravity that's holding them up. Okay? Very simple. Every cell in your body is a little battery, your red blood cell no exception. Minerals flow in, there's locked-in keys, minerals flow in, minerals flow up, open up these channels, nutrients flow in, waste products flow out, whatever. But that little battery, that flow of ions, just like your lead acid battery in your car, with a flow of positive and negative ions from lead, create a charge that starts your car. There's a charge on the cell membrane. And when they try to settle, they literally repel each other and hold themselves up. So what I'm telling you, and Dr. Carter would tell you, is that if your sed rate is not 2, and the reason why I say 2 is because LabCorp never reports 0, the 2 is their bottom number. If your sed rate is not 2, then your batteries in your cells are slightly discharged because of a slight malabsorption of minerals in general or specific minerals. Your gut is a conveyor belt, literally, and an assembly line. And strong acid is the first key, most important part of that, which can lead to an elevated sed rate. But every component of the microbiome has overlapping and specific tasks. So think about an assembly line, and you have 10 stations, and you've been really good with your probiotics and things like that, but what you have is 8 really good workers and 2 not so good. Guess what? Something may go askew in terms of digestion. Like I had people with low ferritin, a little anemia. It can be in the intestine or it can be in the stomach, where you don't have the right components to properly digest iron and other minerals. Not everything digests at the same rate, okay, or with the same components in your gut. So we need to have diversity. And that's what I believe the most important thing to lowering your erythrocyte sedimentation rate to optimal. So you're not clotting, and you are what you absorb. It's really a sign of absorption. Every mineral has different things that will help it be made bioavailable. I tell you to do a simple experiment to explain stomach acid. Go to the grocery store and get vinegar, and go to the hardware store and get muriatic acid, hydrochloric acid. Hydrochloric acid is what's in your stomach. Find a little patch of cement and put some vinegar on a patch and put some muriatic acid on a patch. Come back an hour later and rinse the surface with water and see what you see. On the vinegar, you won't see anything. It's going to look just like the rest of the cement. On the muriatic acid patch, you're going to see clean, fresh, bright, new cement because it literally etched the surface, dissolved the cement, which are stones, if you will, and made those stones soluble. You need to have the minerals that you're eating in solid food solubilized to absorb them. Otherwise, you might have caking in your bowel and have constipation. You know, any sign of dysbiosis could mean an absorption problem. Little bloating, little constipation, little diarrhea, little reflux, little discomfort. Any of those kinds of things can signal that. And that's why this test is so important, because it's extraordinarily difficult to measure where you are on the gut health continuum. And in my opinion, it's easy to get to 2. I had a gentleman that has a little bloating. His labs were super, but he's a 4. He's slightly malabsorbing. And he now appreciates that and wants to work on it. But like sometimes it's very difficult if you've been diabetic to get your blood sugar down below 80, to get your A1C below 5. But I see a lot of people that are healthy, they have a SED rate of 2. That's my goal for everybody, ESR of 2, okay? And so, you know, it's all about the electricity. It's all about settling. It's all about stroke risk. That's why on our chronic disease temperature panel, SED rate actually shows up on several different lines, but particularly the heart and stroke. Because what is heart disease? Your heart's busy, a lot of wear and tear. And if you're not absorbing good minerals, and then your blood's sticking together, you're not recovering, you're not repairing that tissue that's undergoing wear and tear, and your blood can more easily clot. That's a bad pair of attributes, I would say. So let's look at some other data. I love this, sedimentation rate, apparently healthy men. I wouldn't say that someone out here at 95 SED rate is healthy, but you can see a lot of people can get to 2, but these people at 3, 4, 5, and 6, even though my limit is 6 for mortality, but really for good health, I don't think that studies have done enough discernment to look at, you know, just slightly above 2 for me to ferret out what the actual potential of that syndrome is. But you can see that so many people that are apparently healthy, don't have any health problems, have a creeping up SED rate. And in my world, that's just unacceptable. So medical news, inflammation in late teens linked to mortality risk decades later. One of the tests assessed the erythrocyte sedimentation rate. ESR is non-specific, so why would you want it? That's what doctors always say. We don't test that as non-specific. It's like, I want to know what overlaps across many conditions that I can fix. Association between high ESR scores and increased risk of overall mortality. There was a link between elevated SED rate and increased risk of cardiovascular disease or cancer. Absolutely. So here's another study, less than 20, unacceptable less than 20, should be 2. But you can see as the SED rate goes down, percent survival goes up. And I don't want anybody on this curve. I want this curve looking like this, straight across. And that's what a SED rate of 2, as long as other labs are good, will get you. Should we be seeing slide? What should the ESR be? How best to lower it? So, Michael?
Oh, well, like you just described, I mean, it really should be less than 2. And I mean, it's just, it is a marker of total body inflammation, using things like cod liver oil, obviously eating an anti-inflammatory diet. That's, of course, one of the main things. Subacute infections, lowering that, play a key role. Using supplements like curcumin, which is a great, total anti-inflammatory supplement. Whole host of things, but again, we all live in such a toxic environment and eat such inflammatory foods that high sedimentation rate is actually pretty common in a lot of people. But it's not difficult to lower. It really isn't.
One of the things I've been finding, because I'm testing for it regularly, is that if you don't have strong stomach acid, the microbiome that's effective at digestion will be not as robust as it could be. In fact, it starts dying off. The good organisms love the strong acid. Mm-hmm. So something like H. pylori, which is a living antacid, will be disrupting that and causing the good bacteria to go down. And some of those might be involved in mineral absorption that affects this. So, H. pylori, once again, if you look at LabCorp and you do a H. pylori IgG, which is what I do initially, and Dr. Carter does, is they say 0.9 or below is normal. But I find people with reflux that as you get out of good optimal health, that even at 0.3, 0.4 H. pylori, which is considered okay, you still have enough living antacid in your gut to work against your good efforts to improve your stomach acid and the diversity of your microbiome. Next question is, at what age do you consider someone has died early? That's really dependent on the study. So if you take healthy people and unhealthy people, or people with people with like C-reactive, we'll pick sed rate, 2 versus 12, okay? And you follow them, and all we're really doing is looking to see if there's an increase in mortality in the people in the 12 group. So it's not even picking an age. In that respect, it's age agnostic. It's more about longevity focused. So like, who knows how long these people will live, because we're not measuring that in the short frame of that study. But these are probably the people living into their 90s, and we're comparing them against that. Hopefully that's a adequate answer. At what point is WBC too low? I mean, I like you to be 4,400. That's my goal. That's pretty narrow band, but below 4,000, 4.0.
But also with the low range of normal being 3.4, again, it also kind of depends on your diet too. So if you are a true vegan and really follow a good vegan diet, generally speaking, those individuals will have lower white blood cell count numbers. And that's kind of, normalized in that database.
Yep. And Tom asked, how does ozone treatment relate to this cancer risk discussion? Tom, can we hold that one off till the cancer one? But I think, Dr. Carter wants to speak a little bit to ozone therapy and general immune health. Fire away.
Oh, yeah. I mean, I'm a big proponent of ozone treatments. And, you can actually do them at home, having an ozone generator using either like rectal insufflation or ear insufflation, but extremely effective in, killing off bad pathogens, and it is pretty specific for the bad pathogens. It's not going to work like an antibiotic and, decimate your good flora in your microbiome. So, but of course, a lot of the pathogens are, instrumental in provoking cancer production. So by, utilizing ozone therapy and decreasing that just broad spectrum pathogen load, viruses, bacteria, parasites, what have you, then you decrease your risk for cancer.
Yeah, that's, someone asked, is ESR a standalone blood test or is it included among other blood tests? You know, Dr. Carter is the science on the science panel for the Black Health Trust, a group of really, really intelligent docs. And we were on a call about a month ago, and Dr. Carter presented functional medicine to the docs. And we talked about our labs. And one of the docs, very bravely on the advisory board, 12 doctors, one of them spoke up and said, we used to run those tests. And then another doctor, even more brave, said, yeah, and now we don't really know how to treat those values. So you can ask your doctor for a SED rate, but what they're going to say is it's non-specific. I run your lipid panel for you.
Absolutely. And there's no medication for it. So even if it comes back high, they're not going to do anything.
And then keep in mind that when you get the SED rate result back, I want you to be 2. But if you look at normal on SED rate, it's up to 25. You can't make it up.
Right.
You know, when you saw those mortality curves that as you go up above 20 and even below 20, you can't make it up. So like, it's not about the labs, it's about the interpretation of the labs.
Right.
Okay, that are really important. Someone else asked, let's see. As far as replay, I'm working on putting these up on YouTube, but right now I have a problem with my video editing software, which I'm working on. So what level do you want H. pylori to be? So at some point, it'll never be 0 probably, but at some point it's not impactful. I would say on the LabCorp test for IgG, it's 0.2 or below. But you know, as we study more people and do more testing in this space, we'll see if you have bloating and you're having a hard time getting your ESR down to 2 and your H. pylori is 0.2, guess what? I might consider doing some natural treatment for H. pylori and see what happens. You know, on that lower end, it's, you know, there's no data out there in the research because they're not even doing this kind of thing outside of the normal ranges. So it's challenging to find that actual value. But I've had people at 0.35 where they consider 0.9 normal for the H. pylori IgG that still have reflux. And when we treat the H. pylori, the reflux improves or goes away. What ozone machine do you recommend, Dr. Carter?
There's one from a company called Longevity Resources. And then there's another company, I think it's O3 Ozone. Yeah, they're in the $1,500 range. They're not cheap, but quite effective.
Victor says, on my report, the ESR is in the green state at 4. Is that good enough or needs to be improved too, even though it's green? Good point. That's mortality, not necessarily super optimal. It really depends on your symptoms. If you have any indication of gut dysbiosis, a little bloating like the gentleman earlier today that had a SED rate of 4, then that may be telling the story. But in my humble opinion, since repair and recovery is probably the most important disease mechanism, if your SED rate is 4, your red blood cells are settling a little bit. It's telling me that something's a little askew. And my real goal is for everybody for an ESR of 2 millimeters per hour or less. Michael, do you want to just talk about vitamin D dose, even though we didn't, vitamin D levels, even though we didn't go into that today?
Sure. So, I mean, optimal, especially during these times, should definitely be between 60 and 80. Most people, of course, don't have those levels. And the thing is, you won't know unless you test. So that's why we highly suggest that everyone does that. And pretty much everyone should be somewhere between 2,500 IUs and 10,000 IUs of vitamin D3 daily. You also want to combine that with vitamin K2, and an optimal range for the K2 will be somewhere between 100 to 300 micrograms a day. The recent studies show, especially if you have any, cardiovascular disease, using 300 micrograms of vitamin K2 over a period of about a year is extremely beneficial in enhancing elasticity, binding up the calcium deposits. Because again, if you're taking a lot of vitamin D and you don't have adequate levels of magnesium and K2, and this is especially important for women, who are taking extra vitamin D and sometimes they're also taking extra calcium, they're actually giving themselves a higher cardiovascular risk and giving themselves heart attacks, because the problem is when you take vitamin D3, yes, it's going to help you absorb more calcium from your diet, but if you don't have K2 and magnesium, it doesn't send that calcium all the way to the bones and teeth where it's supposed to end up. So it ends up in your arteries and in your kidneys, causing kidney stones, in your joints and so forth, causing bone spurs and what have you. So, but of course, vitamin D, just has a whole host of beneficial, components about it, not obviously just for bone health. It's crucial in, enhancing your immune system. And again, with the outbreak of the virus, that is probably, the one of the top supplements that is beneficial for individuals.
Folks, I have to end it because I actually have a 1 o'clock, but I really appreciate it. And this will be hopefully put up as soon as I can get my software fixed. And then we're going to do another live on the same topic Tuesday at 8 Eastern. So bye for now. Thank you.
Thank you.